Our topic today is dementia etiology assessment and management. My name is Jody Gutkin and I will be your presenter. I have been a physical therapist for 30 years and involved in physical therapy education for over 20, and I look forward to discussing this topic with you today. What we'll examine in our course today are the research that is presented currently related to Alzheimer's disease, Lewy body dementia, as well as frontotemporal dementia. For each of these conditions, we're going to examine the specific pathogenesis, what's currently understood, some of the pharmacologic management, and then we'll focus on specific rehabilitation considerations when you're working with patients with these diagnoses. The rationale for the course is to examine that current literature and what is understood about these different conditions so we can make informed decisions of how to assist our patients best. I have a little bit different approach to the topic than you may have expected, not to scare you off. That I want you to consider as we are working through the course, not just our patients who are already diagnosed with these conditions that are somewhere on the unfortunate continuum of dementia. We're also going to spend time discussing preventative measures and how to be proactive as clinicians to identify individuals earlier who are at risk of developing dementia or are starting to show those early signs so that we can direct them to the right path to hopefully have earlier intervention for more preservation of their skills and cognition. Our goals and objectives are aligned with this. During our first hour of the course, we're going to explore mild cognitive impairment and vascular dementia. In the second hour, we'll discuss Alzheimer's disease, Lewy body dementia, as well as frontotemporal. And then in our third hour, we'll talk about the different assessment tools that you can utilize to help guide your rehabilitation with individuals with these diagnoses, rehabilitation considerations, and specific strategies that you can utilize. All of the different assessment tools that I mentioned, as well as the research studies, are included at the end of the course notes packet in a references list. And then I have specific links available to different resources that I thought would be helpful as you go through your clinical practice. As with any course that you attend, when you go back into the clinic to apply this information, you are going to do so in accordance with the federal, state, and professional regulations where you are practicing, and no conflict of interest exists for the preventer or the provider of this course. As you work through the presentation today, you're going to notice that several of the slides on the bottom right have this icon that says consider this. It's yellow. That's to let you know that those particular slides are going to be helpful when you go to take that course post test later on today. Let's begin with discussing in general brain health and how that is defined. As we look at what is considered health of the brain, there are many different components that tie into that. The first thing that we think of as clinicians often is that motor functioning to control mobility, movement, balance, and then that ties in directly with tactile functioning in order to feel and respond to the different stimuli that the individual is recognizing. Another piece of this is emotional function that we're going to discuss also today. We're going to see how that's a critical point related to some of the different conditions. And this is that ability to interpret and respond appropriately to both pleasant as well as unpleasant stimuli and situations that the individual is in. And then our primary focus today is going to be on this piece of brain health, specifically cognitive health, thinking, learning, remembering, executive functioning. So we're going to see how all of these actually end up interrelating with these different conditions as we focus on cognitive health. And when we look at these different ways that individuals can impact their overall brain health, there are many different opportunities even though genetics plays a role in some of the conditions we'll discuss, to look at changing lifestyle in a positive way to overall help improve cognition and health. And I just wanted to mention that as we work through the course today, I do need to speak in a lot of clinical terms, physiology, and I'm speaking to you as a clinician about your patient. I want to emphasize that I am completely aware that we are speaking about, individuals, human beings with thoughts, emotions, feelings, wants, needs, all of those things. So that is not lost in me. I just need to speak in more clinical terms as I relay this information to you. And please know that everything is heartfelt so that we really can improve the quality of life for our patients who are presenting with dementia, as well as their caregivers and family members. As we look at how our brain functions and how cognition comes into play when we're interacting with our environment, oftentimes cognition is thought of as isolation, that kind of mental processing is sitting there in kind of a silo by itself. As you read the different research and look at the different theories, that as we interact with the world around us, there is a lot more that comes into play. That cognition really has a critical role, and it can almost be looked at in some ways as a central mediator of ultimately how the individual is able to interact with their environment. We know that cognition is controlled in the central nervous system within the brain. It's that mental processing, that ability for the individual to think and remember and organize ideas. Their ability to do that is based on the input and the signals that they receive in terms of perception, that the sensory system is the feeder that cognition relies on in order to interpret and respond to the environment. At minimum, we could say that it enhances perception, enhances cognition. Then we have our cognitive processing, and in order to actually perform different actions, we are going to utilize that perception and cognition to actually perform those functional tasks, to have that fundamental basis of cognition is necessary in order to execute functional tasks, which is why, unfortunately, we see individuals as they progress along that continuum of dementia, that their ability to perform ADLs, to participate in mobility, becomes compromised. All of these connections have further been recognized in how cognition is really broader than just thinking and memory. In 2013, the DSM-5 it introduced new terminology for major neurocognitive domains. And these neurocognitive domains really present a clear view, I think, when we're looking at evaluating and modifying interventions and activities of all the different areas we need to consider that allow an individual to ultimately interact with their environment and perform tasks. It's not just thinking and remembering. So these neurocognitive domains that were introduced, they replaced the former terminology from the DSM of dementia and delirium, and it's not hierarchical. So you don't have one level of thinking progressing to another. It's more we have the different areas that are going to interact. Yes, we have learning and memory, which was previously thought of as our base, but we actually see that things overlap, that we have the ability to attend to what's going on, that has to do with splitting attention, dual tasking, processing speed, working memory, the ability to actually plan and execute, to organize the thoughts, to look at that feedback mechanism when we're working with our patients. We'll talk about, well, they really need to be performing errorless activity to get that feedback when they have impairments of cognition in order for them to be able to execute. Language, we know, also comes into play. And then we can't forget that perceptual ability, that visual spatial representation and the ability to recognize depth perception. A lot of this also becomes impaired when we have the regions of the brain that control cognition that are impacted by different disease processes. And then a big one that is being recognized more recently is emotion, and how emotion is controlled to some degree by these same centers that control cognition. And individuals who have impairments along that dementia spectrum also often have difficulties in interpreting and responding to different emotions in others as well as their own. So, this is a little basis of some of the things we're going to look at today. And really, as I go down this list, you can almost start to envision different ways you might modify your interactions with your patients to better achieve their outcomes and quality of life. And that's what we'll loop back to in that final hour when we talk about our strategies. As we examine cognition across an individual's lifespan, there are different ways that this can be looked at. What's currently understood is that we have our typical healthy cognitive function. That as an individual ages, we're going to have for that individual certain changes that do occur and certain abilities to recognize and interact with their environment. So we have that healthy function. And then as an individual ages, there are going to be some changes that occur related to their ability to recall and remember information. If someone presents with a change in their ability to remember and recall information that happens earlier than it should for an individual of that age, this is termed mild cognitive impairment. And the research has recognized that this is more of that interim state, somewhere between age related changes and that risk of developing dementia. So, this is really where we have an opportunity as clinicians to identify these patients and help get them earlier intervention, because it does increase that risk of ultimately progressing to a state of dementia. What they're recognizing in individuals who have mild cognitive impairment is that there are certain changes that are occurring in the white matter of the brain, more specifically the parietal lobe as well as the temporal lobes, that the communicating structures deeper in the brain start to change. And this is where we're going to see an impact on more of that episodic type memory, executive functioning, just starting earlier than it should. Dementia risk is when individuals have that decline in their cognition that then leads to an impairment of their functional mobility and their independence. Now, the key here is that dementia is not inevitable, that there are opportunities to step in to slow the process to help preserve what the individual may have left. Yes, the disease processes will continue, but hopefully we can see at the end of today there are opportunities where we can step in to recognize that that dementia is not inevitable. To do a little bit of a comparison to help see these differences between age related and then dementia, age related memory changes might be that you know when your best friend's birthday is, but you're going through your day and you forget, oh my gosh, today is March 5th. It is their birthday. I got to call or text them. So that's normal age related changes. Mild cognitive impairment would be you forgetting, the individual's forgetting those things that they should normally recall. Now, if they can't remember the name of that best friend, that would be mild cognitive impairment, or a conversation that they just had with that best friend. Dementia, in contrast, would be they just had that birthday dinner with their friend, but they can't remember what they ate at it. If you reminded them that they had spaghetti and meatballs, they might still be able to tell you how to make those meatballs, but they still might not remember that's what they just ate, because that's the difference between episodic memory, that autobiographical, from that semantic memory, how to do things. And we'll look more at that. There are many different contributors that have been recognized to brain health. And when we examine this, we're going to see these different opportunities that we have as clinicians to positively impact our patients. And a lot of these epigenetic factors are where we can play a direct role in therapy. So, managing blood pressure, cholesterol, and glucose, looking at positive lifestyle changes for the individual. It is recognized that engagement and social activity is important. Reading, games, learning a new language. So, when we're working with our patients, particularly on their discharge planning, regardless of what diagnosis we're seeing them for, they may have a comorbidity of some of these conditions. They may have mild cognitive impairment, even if we're seeing them for that total knee replacement. And even if not, we want to be forward thinking for all of our patients in developing a discharge plan that maybe we can double dip, that we're looking at contributors to brain health and developing a discharge program for them, an exercise and wellness program that can hit on multiple factors along with the primary diagnosis that we're seeing them for. The reason we want to emphasize this is because physical activity is directly linked to brain health. That there was a physical therapy specific study that was completed at the Cleveland Clinic Brain Health Center, and they did a retrospective analysis. They pulled the charts of patients over a 2 year period, and they looked at individuals between 50 and 90 years old, those at the greatest risk for dementia, and they examined those patients who had at least 1 month of physical therapy. Now, it didn't matter what was actually performed in the physical therapy. They were just looking at that there was a level of aerobic strengthening balance and specifically dual tasking to hit that cognition a little bit too. And it didn't matter what diagnosis the individual was being treated for. So they looked at cognitive function, and then they looked at who went on to develop different types of dementia. And they actually found with the different types of dementia that individuals not only improved their function, but they also had improved cognition that was directly linked to that participation in activity. The research is saying, well, what is that factor? Why do some individuals go on to develop dementia while others do not? What is that kind of missing link? And they're trying to formulate that if we look at, well, what is considered successful aging, the thought is trying to preserve that thinking, reasoning, planning ability along with function throughout life, and it's shaped by the individual's different experiences that they are involved in. So, a primary factor that they're finding is called cognitive reserve. And cognitive reserve is being defined as a couple of different factors coming together to kind of create that brain state. And they think it's explaining why we see different presentations, even if someone has the same amount of physiologic damage to the brain or pathology that would impair these different centers that we're talking about. Why are some individuals still able to function at a higher level? And there are a couple of factors that come in. They think one of them may just be synaptic density. I think of this like the hardware. Maybe some individuals have just better hardware to start off with. Another component is looking at cognitive effectiveness or redundancy. So think of this like the software. So this is the individual who has a richness of language over their life. They have occupational complexity. They have a lot of social engagement. And then the last factor is looking at the level of physical activity and motor skills that the individual has been involved in across their life, that physical activity component. The way this has been figured out is that these factors come together, and even with the same degree of damage, we're seeing varied presentation and preservation of the different areas of neurocognitive domains that we discussed. So the Rush Center for Memory and Aging Project, the way they came to this is they performed a battery of tests on individuals, all different clinical assessments on volunteers, and they followed these individuals, and the individuals volunteered to donate their brains at the time of death. And we're so thankful for people that do that, because in 2019 they were able to put together these different pieces of the puzzle from these 450 participants. And over the years, they followed individuals looking at their level of physical activity with this accelerometry. They did different cognitive assessments on the individuals, and then they were able to examine their brains and look at signs of Alzheimer's disease, the formation of Lewy bodies, the amount of hippocampal sclerosis that had occurred, and then look back at their ability to participate in exercise and how they live their life. And they did find this connection, particularly with physical activity for those individuals, that those individuals, even if they had the same physiologic changes in their brain, the ones that participated in physical activity had richness of cognitive challenging throughout their life, particularly later life. They functioned at a higher level than individuals with the same amount of brain damage that did not have that. A specific study in Sweden examined women who remained socially engaged throughout their lifetime, and they looked at them over a long period of time. This is commitment to a study, and again, thank you to all these women. They examined them from 1968 to 2012. So the mean age where most of these women started were, it's somewhere in their 40s, and they followed them across their lives, and they looked at what they were involved in, and ultimately, did they go on to develop different forms of dementia? And what they found is those individuals who were really participating by choice in their lives in intellectual type of activities, artistic, different things. So, for example, some of the women that had less dementia and less risk of Alzheimer's disease were those who read at least one book in a period of 6 months. They participated in moderate, gardening, which takes thinking as well as physical activity. They were singing in a choir, or they were on the board of an organization. They were somehow engaged and involved. They had decreased risk of the Alzheimer's disease and less total dementia. Those individuals who were also participating in physical activity regularly, they found that those individuals had a decreased risk of the different forms of dementia, particularly vascular dementia. Those individuals had a 53% decrease incidence of stroke. And then the individuals who had more of those cognitive activity throughout their life, they had almost a 46% less incidence of developing Alzheimer's disease. So opportunities here for us, even in the complexity of the interventions that we perform. Let's assign this to some specific diagnoses now. That was just our baseline. So, when we look at the different types of cognitive impairment, subjective cognitive decline first, that's when an individual just reports that, I'm just not remembering things as well. These are individuals that just have that self-report. There may not be anything else specific we can attribute that to. What they are finding as they study these individuals is that 1 in 9 of them are under the age of 45, that 81% of them have at least one chronic comorbidity, such as coronary artery disease, chronic kidney disease, some chronic condition. And what's most troubling, but an opportunity for us, is that the majority of these patients in the studies did not report it to their physician that they were experiencing changes in their memory. So the CDC and the Alzheimer's Association partnered to try and increase awareness of cognitive decline and to try and encourage people to talk more to their physicians. And our patients talk to us, right? And their family members do, or we just might notice things over the time that we're seeing them. And this is really the opportunity here. And it also is something to trigger us to think about. We maybe should consider doing cognitive assessments, even a quick brief one, on more of our patient populations as part of our screening. Mild cognitive impairment is considered more of a progression. This is what we talked about, that individual where it's a specific diagnosis, that individual has greater memory impairment than they should for someone of their age. And then lastly, dementia is when the individual, this is a much more serious condition in terms of how it impacts the individual's function. It's more of an umbrella term for a range of symptoms that impair not only cognition, but physical ability. And we're going to examine the pathologies that fall under each of these. Mild cognitive impairment, this is not a type of dementia, but it's again recognized more of that kind of interim state between someone having just basic age related changes and then moving towards that development of specifically Alzheimer's disease. Someone who presents with this earlier in life is more likely to have Alzheimer's disease. It's estimated that somewhere between 5 and 25% of individuals over age 65 have at least mild cognitive impairment. Another reason we should probably be doing some of the screens we're going to talk about in the last hour, to identify these individuals. And then these may be the things that are hard to notice this population, which is why we might need some type of assessment to identify them because they compensate really well. This is the individual who is using notes to remember things. They may be forgetting a conversation that they already had. They may be repeating things more often. Maybe they're forgetting their appointments or to pay their bills, repeating the same questions over and over. And these are things we could potentially identify in therapy. They're also noticing that individuals tend to have challenges with three-dimension um, vision, and this is that visual spatial piece of the neurocognitive domain. So maybe they're having difficulty with stare negotiation that isn't really attached to anything else, and you're pulling these pieces together. So if you have that patient that is, forgetting to pay their bills or forgetting to come for their appointments, and you start to see a pattern, consider that, could it be this mild cognitive impairment? Management strategies for someone presenting with this, it could be due to an underlying condition. There are sometimes underlying illnesses, depression, anxiety, that just lead to that cognitive impairment, potentially thyroid disease. And if those things are identified and managed, then we might see these symptoms of mild cognitive impairment diminish. The guidelines from the American Academy of Neurology for management of this condition is that healthy lifestyle, increasing exercise. Their estimate is that it takes about 6 months of moderate to rigorous exercise at the level for that individual to see an improvement in their cognitive function. socialization. We're also looking at, in terms of cognitive interventions, these are individuals who are doing word finding, crossword puzzles, playing cards, different things to keep their mind active combined with physical activity. And that might give you some ideas as we're working on balance training. Could we be playing cards with the individual? If in occupational therapy, maybe we're working on balance for sitting ADLs if the person's at that level. Well, is it possible that, they have to reach for the pencil, reach for the book as they're trying to do a word find or a Sudoku or something like that? So maybe we can get creative in enhancing the cognitive demand on our activities for our patients. As we look at dementia, dementia is going to be a collection of symptoms. This is that slow progressive decline in mental functioning for the individual. We tend to think of memory as the first impairment, and it is involved for most individuals with dementia. However, we're also going to see these changes in the executive thinking and the judgment, the organizing, the planning. Personality and behavior changes can also occur, which do not allow the individual to necessarily interact appropriately. And then also, language can be impaired for the individual. And you want to take a moment to distinguish dementia, depression, and delirium. So, dementia is going to be that slower, long term progressive impairment that leads to ultimately the individual for a limitation in their ability to care for themselves. Depression is different. Depression typically is going to start earlier on for that individual in as that mood disorder, where they're going to start with maybe not being up and moving as much, not being engaged as much, eating, sleeping impairments, more of those kind of functional aspects impaired earlier on versus dementia, it's going to be later on. We're going to just generally see more decreased alertness with depression. Delirium, on the other hand, delirium is more of a sudden onset, and it usually has a clear start of when it happened. It's more of a fluctuation in mental status for the individual, and it is reversible. It may be due to medication withdrawal, an infection, such as a urinary tract infection, and it's more just a confusion of thinking. So, when we're looking at our patients, we do need to make that distinction between dementia, depression, and delirium so we can make appropriate referrals as necessary. As we look at the different etiologies of the different forms of dementia, we're going to look at those conditions that are reversible. We have certain that are different types of vascular dementia. And these, if we kind of split here between these etiologies, the ones beneath this, the secondary dementia and the primary dementia, those are more of our neurodegenerate types of conditions, whereas the reversible and the vascular have other etiologies and they're classified differently. So we'll examine each of these. Normal pressure hydrocephalus. This is a reversible form of dementia where the cerebral spinal fluid is not flowing appropriately. It's going to be blocked somehow, either in the spinal cord or in the brain, wherever it's blocked, or overproduction. And what happens is, as that builds up, we're going to see a change in the ventricles for that individual. So, if we look at this image on the far right, as we examine the individual, we're going to see changes in those ventricles and enlargement of them because of that change in the cerebral spinal fluid. And this is going to place pressure then on different brain structures that can lead to that individual. Often, what's noticed is a specific gait impairment. This is the individual when they're ambulating. We need to distinguish it from a Parkinsonism type of gait. It looks like they're on a boat trying to balance and they're kind of like stepping with their feet. Sometimes it's called like a magnetic gait where they're trying to balance. Incontinence is also present along with the mental impairment. Someone with Parkinson's disease, their gait is going to be more of that, festinating type, where they're starting to sit before they finish turning around. It will look differently. And as clinicians, we may be involved in the management of the normal pressure hydrocephalus because if this is the condition, it's important to distinguish it. They'll place a shunt in for that individual, a ventricular peritoneal shunt, and then they will allow that to function for about 3 days in acute care, have physical therapy, do another evaluation, see if the symptoms have improved to recognize that this is the condition. So we need to consider this as a differential diagnosis for our patients who are presenting with Parkinsonism, balance deficits also. Vascular cognitive impairment and dementia. This is going to be when there is specifically a vascular origin. Individuals with Alzheimer's disease can develop this, but is separate condition. A CVA, we're all very well versed in. There's going to be a specific lesion in a specific area of the brain. Sudden symptoms will occur for the individual. And if it happens to be in the areas that manage these different neurocognitive domains, memory, thinking, executive function, then we will see those impairments. Sometimes this is referred to as post stroke dementia. Cardiovascular disease and diabetes, what they're finding is individuals who have long term stress through high blood pressure or atherosclerosis being placed on the vasculature in the brain, they're going to see that narrowing of the lumen, that decreased vascular flow to different regions of the brain that lead to ischemia as well as neuronal damage or death. Specifically, what's noted at the tips of those red arrows off of here is there's white matter thinning that is occurring. There's axonal changes, and these plaques and changes seem to happen in the areas that are related to cognition. So, again, exercise managing cardiovascular disease can help. When we look at the presentation with individuals with these different vascular impairments and how we can distinguish their cognitive presentation from someone, let's say, with Alzheimer's disease, the big difference is that someone with Alzheimer's disease is first and primarily going to start. We think of that memory loss component, particularly that autobiographical memory. When someone has these different types of vascular dementias, it's more organization, attention, problem solving. So, more of a speed of thinking challenge for these individuals versus memory impairment for someone with Alzheimer's disease. Also, with the vascular cognitive impairment, we'll be able to attach the concurrent language deficits and personality changes that the individual may be evidencing to the different regions of the brain that are affected with their specific pathology. Management for the different types of vascular cognitive impairment are going to be focused on protecting that neurovascular unit within the brain in order to preserve that brain function for the individual. And this is a huge opportunity for us as clinicians. There are big initiatives out there from the National Institute of Health and the CDC to educate individuals more on managing blood pressure, diabetes, heart disease, in order to help kind of stave off the negative effects of the vascular cognitive impairment. They have many different infographics available and resources that I included links to at the end of the course notes. If you're looking again for an opportunity to, post things in your clinic or different community outreach, and again, to be forward thinking in your discharge planning to incorporate not only brain health, but heart health activities that can help your patient moving forward. And what they're seeing in terms of ideal blood pressure management to reduce the risk of this type of vascular cognitive compromise, that what they're seeing in the research is better midlife management of blood pressure leads to less risk of this type of dementia later in life. There was there was a Sprint Mind survey that clinical trial that it took over 9,000 participants, and they followed them for a 5-year time period. And what they looked at was managing these individuals to keeping their blood pressure less than 120 systolic. So keeping it intensively significantly below that 140 risk factor of the systolic for heart disease. And they found that through the National Institute of Health, such a significant improvement, actually in neuroimaging, less of that white matter compromise from that high level of exercise. Again, high for that person, that they actually had a couple different trials going, and they said, you know what, for those individuals who were in our control group, the results were just too amazing to keep them in the control group. They actually stopped that arm of the study and said, okay, everybody needs to benefit from this. So kudos to them for recognizing this. The National Heart and Lung Institute did again another study looking at that, where they took individuals in the late 80s and they studied them for 2 years, their activities, their lifestyles. And then in the mid 2000s, 2011 ish, they followed them for 2 years, 25 years later, to kind of look at lifestyle and how they managed, and then the risk of these different types of vascular dementia. I like that they worked with individuals from different parts of the country, from Maryland to North Carolina to Mississippi, Minnesota. So we had, different groups of individuals, and they found that certain precursors we know, or lifestyle choices, tobacco, diabetes, that hypertension, those individuals did have a significantly higher risk of later life dementia if they engaged in these activities midlife. So, those are some things to think about related to different forms of dementia where we have an opportunity to improve patients' future cognition with what we're doing with them currently, to be more preventative in nature. Now we're going to take a look at Alzheimer's disease. So, this is probably where you thought I was going to start. We know that this is a primary form of dementia. It is a neurodegenerative disease that leads to that progressive limitation in cognition and ultimately the individual's inability to physically function. There are some different presentations. We have a late onset, which is probably the most commonly the population that we're seeing. These are individuals who are presenting in their mid 60s. And the genetic component that they find, the culprit is the apolipoprotein E, specifically 4. This gene this is responsible for carrying that cholesterol across the different membranes and carrying different things in the bloodstream related to the management of cholesterol. They're not really sure exactly why it's that number 4 component of it, but that's the one that they're finding as the precursor because there are several different alleles. Early onset, what they're recognizing for individuals who present between age 30 and 60, there seem to be different genes that are responsible for that. The amyloid precursor protein, and then we have the preslin 1 and 2. So these seem to result in the abnormal production of some specific proteins that ultimately contribute to the development of Alzheimer's disease. So we're looking at, they're early on in some genetic screening to recognize the precursors to the development of the physiologic changes that lead to Alzheimer's disease. As we look at the pathogenesis of Alzheimer's disease, they don't fully understand all of the contributors, all of the genetic, environmental, and lifestyle factors that kind of like trigger those genes to start this deterioration process. But what they have recognized is what actually happens in the brain of the individual who has Alzheimer's disease. And what's recognized are what we call beta amyloid aggregation. And beta amyloid, there's an overproduction or a delayed clearing of this amyloid protein that is normally present in the cells. There's just either too much or the body's not clearing it. And as it builds up, it becomes misfolded and it creates these plaques in the kind of in between the nerves of the brain and alongside of them. They're like insoluble clumps of protein that just can't be cleared. And as they start building up in that area between those nerves, that's neurons, I should say, of the brain. That's when we're starting to see those kind of preclinical stages. So, this is why it takes time for the symptoms to be evident and the impairment to be evident. Concurrent with this, what they're also saying is an impairment with the tau protein. Tau protein normally should be in our brain, and it plays a role in keeping those neurons, that their microtubule, kind of their skeletal shape intact to allow transport and conduction. So that's what the tau protein should be doing. What happens in the individuals who present with Alzheimer's disease is that the tau protein, it becomes unstable and it goes through phosphorylation where it starts to break down. And as that tau protein breaks down, that nice long slender structure that we see here of that neuron and the ability to transport and conduct is lost, and it starts to destabilize, and that's why it tangles. And it creates these what they call neurofibrillary tangles that kind of fold over and twist on each other. These two processes together, they are what we call a self-propagating. Some of the research says that these are the seeds of corruptive templating of those neurons that continues to lead to neuron damage. Particularly, we're seeing that this neurotoxicity and damage and dysfunction and deterioration of these neurons is particularly happening in the hippocampus, that is really playing a role in encoding memories for the individual, and in other areas of the cortex that's involved in more complex thinking and decision making. And ultimately, it leads to that brain atrophy and dysfunction for the individual. That's mainly what they see is happening with Alzheimer's disease. They're also noticing that there are some other contributors to the neuronal dysfunction. It's almost like as those amyloids are forming and the tau proteins are becoming dysfunctional and destabilized, that there's this cascade of other events that is happening within the brain. They kind of call them like secondary effects in response to this damage. And they're finding that there is a decrease in acetylcholine synthesis. And acetylcholine, we know, is that important neurotransmitter for the individual. So that decrease in the neurotransmitter is happening in the regions of the brain for learning as well as memory, arousal, concentration, some neuroinflammation, the mitochondria are damaged. So many other things are also happening. One group of individuals I want to emphasize are those individuals who have Down syndrome. There appears to be a connection between Down syndrome and the development of Alzheimer's disease. They're at greater risk specifically for early onset Alzheimer's disease, um, particularly before age 40. What they're finding as they look at someone who presents with Down syndrome, that the brain is already demonstrating some of this neurodegeneration. And then by the age 50, because it takes time for the nerves to degenerate to a point for the individual actually to have impaired functioning, that by the age of 50, individuals are having clinical symptoms. And then by the age of 65, they have dementia. The reason is because the chromosome 21 that is related to Down syndrome, it also carries the gene for the apolipoprotein that is connected to that Alzheimer's disease. So that seems to be the connection there, that leads to more of an accelerated plaque development for these individuals. The concern is that So if you're working with someone who has Down syndrome, for whatever diagnosis you may be seeing them for, they may be, completely independent otherwise in their lives, or need assistance for certain things. We should be doing a cognitive screening on them because there is a direct link that's noticed here, and we want to recognize it earlier because unfortunately, by the time this individual is demonstrating their impairments, their parents who might step in to be a caregiver, they're in advanced aged already. So we really want to look at being proactive when we're planning for this population. The clinical presentation that we see for individuals with Alzheimer's disease, we already all have experience with these individuals and we know how it presents. So, what I want to take a little closer look at are where the proteinopathies are occurring and the specific regions of neurodegeneration in the brain, because it really helps us paint a clearer picture beyond memory being the singular impairment for these individuals. So, the University of Pittsburgh, in conjunction with Swedish researchers, they developed what's called Pittsburgh Compound B. And they're utilizing it in studies because there is that uptake by the amyloid plaques. And then they did PET scanning on individuals to really highlight the areas where there is deterioration related to Alzheimer's disease. And what they're seeing is that in the brain, in this preclinical stage, they can actually find plaques in the brain 20 years before any clinical symptoms even start. So, that might, during that time, that's when that individual might be demonstrating kind of those subtle memory impairments that maybe only the person living with them recognizes because they're compensating somehow. They might just be having like delayed recall of things, demonstrating some apathy related to involvement of life. Maybe they're just more irritable for no reason. Some of those preclinical type of presentations. Um, Before it goes to that prodromal stage where the individual has that mild cognitive impairment that we discussed, where they have a decrease in their learning curve, or I should say increase. It takes them longer to learn new tasks. There's decreased engagement and involvement in life activities. They're repeating questions. They have difficulties with problem solving. So maybe you're working with them on a complex exercise and they just can't figure out, well, how do I adjust the weight machine and then get myself sitting and situated before I start the exercise? They're just not sequencing things well. We're starting to see a decrease. For that individual, as they move towards the stages of dementia in not only ADLs but IADLs, BADLs, all of those areas. That's what we typically think of. What we want to expand our thinking to be comprehensive, are these different areas of neuroimaging that they're recognizing. So, what they're seeing is in terms of areas of the brain that are impaired, we see that there is decreased uptake here in that occipital lobe. Let me change my pen color. decreased uptake in that occipital lobe. And what we recognize in individuals is that because of that, this is why they're going to start to develop hallucinations, where they're going to have challenges also because of this change that we're seeing in that temporal lobe for the individual, that memory, that ability to hold on to new knowledge and encode it so that in learning new tasks, just repeating it and doing it a couple times, we may not see that carryover session to session. We may need to add other cueing and assistance for carryover. That parietal lobe involvement, we're going to see language impairment, perception impaired for the individual, word finding difficulties, comprehension difficulties. So we might need to make our exercise program simpler, even our cues and who else, what else we have going on in the gym and the clinic when we're working with that individual. If we're in home care, if we have the TV on, that might be a little bit too much because they're also going to start developing different hallucinations that might be occurring. And then also that obvious frontal lobe involvement where we're going to see motivation, planning, sequencing of events also. There are different risk reduction behaviors, some of which we've already mentioned related to the other types of dementia. As we examine this specifically related to the presentation of Alzheimer's disease during that preclinical or prodromal stage for the individual, what the studies, one study did was they followed individuals over a period of 5 years, and they had them participate, or they assessed how many of these different risk reduction strategies the individuals participated in. So not smoking, high level of physical activity was considered going with that heart healthy model of greater than 150 minutes per week of exercise, looking at least a moderate intensity. In terms of the diet, there's the mind diet. It's a modification of the heart healthy dash diet, specifically looking at being brain healthy. So it incorporates the same whole grains, veggies, beans, fish, things like that, but it also includes a higher intake of vitamin E, folate, flavonoids, vitamin B, and then cognitive engagement for individuals. What they found is they compared individuals who only participated in none to one of these activities to individuals who participated in two to three. And what they found that the individuals who participated in two to three activities were at a 37% less risk of developing Alzheimer's disease. Those who participated in 4 to 5 of these activities were at a 60% lower risk of developing Alzheimer's disease. So, again, research is supporting a lot of opportunities here for us. If someone is progressing in their stages of Alzheimer's disease, if the progression does not slow for the individual, what we see is a specific classification. Someone who is in an early stage of Alzheimer's disease is considered with mild cognitive impairment. This is an individual who maybe their emotions are a little unpredictable, difficulty planning, but they're still independent in all of their functioning. Someone who is at the middle stage of the disease with more of a moderate impairment to their cognitive abilities, this individual, they're needing some assistance. However, they are still able to learn new things. We still have opportunities here to help improve the functioning for this individual. So they have learning and memory is decreased, so we need to look at different strategies. They may need some assistance for their ADLs, but this is the person who, in terms of their cognitive impairment, they may not recognize you as the same person that treated them last time. They may not recognize their family member. Maybe they're hearing the family member's voice, but they're not seeing that individual to be present. So they become confused by that. Maybe they're getting lost more often. And then someone who is in the late stages of Alzheimer's disease, unfortunately, this is the individual who they're just not able to interact with their environment. They may not recognize their own face, so having mirrors around is probably not a good idea because that can just be extra disturbing for that individual. They may not be able to speak or communicate. This is where swallowing may be becoming impaired. We're concerned about pneumonia, pressure sores, and we're looking more at making them comfortable and avoiding complications. A way to communicate to the individual as well as family members what is going on and what the different impairments are is we can use the 4 A's of Alzheimer's disease. I think this is also a good way to remember it if you're not working frequently with individuals with this diagnosis. Kind of keeps it in your head. And then if you're trying to notice, maybe someone's not diagnosed, but you're seeing patterns here that you may think that you need to make a referral. So, what we're going to look at in terms of that memory, our A is amnesia. The individual is going to have challenges with episodic memory. That's the autobiographical information, that's that new information that they're being taught, versus semantic memory is okay. That's that long term memory. So maybe that individual doesn't remember to wash their clothes, but if you ask them how to do the laundry, they can tell you how to do it. They just don't think or remember that they need to, wash their underwear and put on a clean pair, for example. In terms of aphasia, this is the ability to communicate as well as understand communication. So we're going to look at how we need to cue that individual. Apraxia, looking at the individual's ability to perform specific movements purposefully, brushing their teeth, feeding themselves. We have to recognize that this apraxia also extends to the individual's perception and how they experience pain, temperature, touch. So if they're in earlier stages of the disease, they may be able to communicate that to us once we identify it. In later stages of the disease, we're going to have to look for more um, auditory articulation or nonverbal communication if they're, hot or uncomfortable or in pain. And then agnosia is where we're looking at visual changes. Like I said, they're hearing the voice, but they're not seeing the person's face. They're not recognizing familiar objects. So maybe they are not going to the bathroom in the toilet, not because they couldn't get to the bathroom, not because they just wanted to. It might be because they thought that chair looked like the toilet. It's part of that agnosia. As we look at pharmacologic management of Alzheimer's disease, there are different medications that are available. The first category that we will discuss are the cholinesterase inhibitors. If we rewind, to what we discussed earlier about the pathophysiology, we said that a secondary effect that's happening in the brain is less acetylcholine, therefore less neurotransmission. So what they're finding is that if they take a cholinesterase inhibitor, that if we look up here at the top, we have that acetylcholine trying to go across the membrane. There's already not enough of it present, and acetylcholine esterase is going to break it down as it's coming across. So that inhibitor is going to stop the acetylcholine esterase from breaking it down, so there will be more acetylcholine present. That was probably what, like an hour worth of studying when we were back in school. And now we're like, oh, yeah, that's what it is. Okay, so taking that to another level, something we need to be aware of with our patients is if they tell us that they're taking, or we know in our medication review that that individual is taking other medications, certain antidepressants, certain bladder medications for incontinence, those medications are actually anticholinergic agents. So basically, they are going to reverse everything we just did. So these two medications are going to fight with each other. And as a result, the acetylcholine is going to be blocked. Thus, that Alzheimer's disease medication is not going to be as effective. So we got to watch that for medication interactions. Next, if we take a look at NMDA antagonists, just to briefly explain how those are working, as we look at glutamate and glutamine presence, the NMDA is going to increase the binding across the neuron. So, what we're finding is that as they go through these different clinical trials is that it's going to help increase conduction. And we have glutamate and glutamate is going to stop the binding. And what they find is if they're able to kind of over stimulate or stop the binding of our inhibitor, it'll allow more of this glutamine to cross the membrane, and the I shouldn't say membrane, I should really say synapse. Um, It'll allow it to better cross the synapse, and that will allow for greater stimulation and greater neuroconduction to hopefully preserve some of the functioning of those nerves. They're coming up with other medications, looking at amyloid agents, other specific tau agents. What I do want to emphasize is that the FDA does have a black box warning out there that patients who are taking antipsychotics with these different medications, we have an increased risk of stroke. So we do want to educate them and monitor them for those signs of a potential stroke. A newer medication is aducanumab. And what this actually medication at the time of my presenting this through the FDA, it has received an accelerated approval because it does appear to actually reduce that amyloid plaque formation. Now, it's not going to change the plaques that have already formed, and we also have that tau tangle piece, but it does appear to reduce the formation of new plaques to help slow the progression. What we need to know to monitor our patients for is amyloid related imaging abnormalities. ARIA is what they're calling them. And what they're finding is that in some individuals, this is a monthly infusion that the individual goes for, that after the infusion, they're developing brain swelling. And that brain swelling is going, and brain bleeds actually are going to be evidenced as headache, dizziness, nausea, confusion, vision changes, all those typical signs and symptoms we would look for. Um, So we really need to monitor patients for this. And in one particular research study, 4 in 10 patients did develop the brain swelling and bleeds to the point where they had to stop the medication. And then 4 in 10 developed the symptoms, and then 1 in 10 had to actually stop taking the medication. So we do need to monitor our patients for this, but they are starting to come up with more medication management. Exercise is going to help support our patients with Alzheimer's disease. The idea is they think that it's going to help with formation of new blood vessels, new blood supply, help increase that connections within the brain, those synapses. And then they also think it might help with actually the formation of new neurons that is overall going to help improve that brain health for the individual. And what they're finding is that exercise in different forms can be helpful. It's not just one particular type of exercise, that there are different types of exercise that are beneficial in this process. And again, the goal is to help preserve functioning for as long as possible for the individual. Examining some specific studies that looked at just aerobic training for individuals at different stages of Alzheimer's disease. They haven't come up with one specific protocol that's best, so I just pulled a couple of different studies for us to take a look at. They looked at individuals who were in early stages of Alzheimer's disease, and they had them participate in strengthening as well as aerobic exercise. So the aerobic exercise cohort, they were participating in 3 to 5 weeks of aerobic activity over a period of 6 months, because that's about what we need to see a cognitive change. Same thing with diet. So the goal was for them to, the first week to do 60 minutes of exercise, increasing up to that 150 minutes. Target heart rate range that they were utilizing is they were starting at, 40 to 50 percent, and then increasing the person eventually to be working up at 60 to 75% of their max heart rate. They did find in these individuals that there were cardiorespiratory improvements, improved function overall. On imaging studies, there were improvements in the hippocampus. It retained more of its density. However, they didn't see any specific cognitive changes for the individuals, but they projected maybe there would be more changes as the disease would have progressed, because we're seeing those physical changes in that hippocampus. Another study examined individuals who were carriers for the genetic marker, or the gene for Alzheimer's disease. They've looked at this in many different animal as well as human studies through different systematic reviews as well as specific studies. And what they did find that exercise led to improved memory, less neuropsychiatric symptoms for the individual, and then again, they were physiologically able to see less changes in the brain that they anticipate will lead to better cognition and improved quality of life. Their thoughts here on all these different studies is that it may help, like the exercise helps to somehow ameliorate and be a non-pharmacological way to help stabilize the cholesterol and the pro-inflammatory signaling that contribute some of those secondary factors also. Examining resistance training, there was this one animal study where they had the mice with pre-existing cognitive impairment, and they put these little weighted vests on them and had them go up and down these stairs, and they did find improved cognition. Again, less pathology physically present on imaging studies, and they compared those to mice that were sedentary. Looking at individuals who were presenting with mild dementia and some specific strengthening activities in human studies, the individuals participated in a 4 week training. They did include aerobic activity of vigorous biking for the individual. Or treadmill, and then they did 4 days a week of that, and then they did 2 days a week of strengthening activities, follow them over many, many weeks. And what they did find is that, again, the neuropsychiatric symptoms decreased, mental cognition, as well as their speed of thinking, specifically, their ability to attend more to what's going on and what they're learning, seem to improve. So the research is saying that different types of exercise are beneficial. Our next condition that we're going to discuss is related to Lewy body formation in the brain. So we're shifting gears a little bit here. Lewy bodies are these clumps of alpha synuclein that occur. They're those misfolded versions of a specific protein in the brain. And as these little misfolded proteins develop in the brain, based on the area where it happens, we're going to see different clinical presentation for the individual. Ultimately, what they do is they don't allow the neurons to conduct the impulses and to provide transmission and allow the different centers of the brain to communicate. So this is alpha synuclein. Before we were talking about the amyloid proteins with Parkinson's disease. So as a broad category, when we look at Lewy body, if they are forming in the cortex, we're going to see the individual with clinical presentation of visual spatial changes, apathy, hallucinations, that typical cognitive impairment that we've been discussing related to dementia. When they form in the brainstem of the individual, this is where we're going to see depression, sleep disturbance, more of the Parkinsonism non motor symptoms that target the autonomic nervous system. In the substantia nigra, it is going to cause disruption in the functioning of that extrapyramidal system. So that is our system that is our automatic functioning. So the fact that I am able to maintain my balance and I'm not falling over here as I'm speaking, that I am able to kind of have certain things going on in the background that allow me to have postural control and balance and remember how to move this mouse without actually thinking about it, is that extrapyramidal system. That's where we would see those typical Parkinsonism type traits, bradykinesia, motor changes. And then we can also see changes in the gastrointestinal system. If we think of those plaques as they can build up in those different areas of the brain, that broad category of disease process is called Lewy body dementia, because it's those Lewy body formation that have caused the dementia symptoms that the individual is seeing. And then it also, we're going to see other symptoms because of these other areas of the body where the alpha synuclein has accumulated. So this branches off to two specific conditions. The individual can have dementia with Lewy bodies, meaning the Lewy bodies cause the dementia. That's the primary pathology. Or the individual can have Parkinson's disease, where these Lewy bodies have formed, and as the disease progresses, then we're going to see the dementia develop. And the dementia is actually a symptom of the Parkinson's disease, so it's a secondary dementia that's occurring. So we're going to look a little bit more closely at the difference between these two because it is important to understand. It gives us a clearer picture of where the patient is at with their primary disease and what to expect in terms of progression so we can meet their needs and that of their caregivers. Dementia with Lewy bodies, there is a genetic predisposition to this. There are some biological factors that are going to contribute. They haven't quite honed in on it. The dementia with Lewy bodies as a primary dementia is the second most prevalent neurodegenerative dementia, right behind Alzheimer's disease. This is actually what Robin Williams had. A lot of people still think he had dementia or some other neuropsychiatric disease, but he actually had a dementia with Lewy bodies. It's often confused with other psychiatric disorders. And the challenge here is in addition to what I've already explained, acetylcholine and dopamine are ultimately going to be impaired. That's why we're going to see changes in behavior, cognition, mood, sleeping. And there is no one test to diagnose this, it is a diagnosis of exclusion. The clinical presentation for someone with dementia with Lewy bodies, this is a very aggressive disease course. As it spreads through all those different brain areas that we looked at, it may be mild initially for that individual where they're still functioning fairly normally, but then in the later stages, they become dependent very quickly. The disease condition is primarily going to involve a decline in thinking for that individual. So it's a thinking impairment. For this person, they're going to have decreased concentration, attention, alertness. You may have a conversation with them one day and then the next day they don't remember it, and this is consistently. Their level of alertness is fluctuating between they're attentive, they're on top of things, and then they're just not there. The thinking is going to be difficult to analyze things. They're going to have, if you do the copy and draw like the clock test, they're going to have impairments in their ability to do that. They're not going to be able to attend and focus for long periods of time. So this means they're going to start to have problems with IADLs, like their finances, doing their banking. Their speech will start to come very disorganized. So we're early on going to see memory impairment also for this individual. It and early on, that memory impairment is because of these other things I described, that lack of attention, that lack of concentration. Later on in the disease, it's truly memory impairment of that section of the brain. And then as the disease progresses, we're going to see the motor symptoms of Parkinsonism start to present for this individual. And as we combine all of this together, we're looking at an increased fall risk for that person. So it's cognitive first and then motor second. Sleep disturbance for this population, we want to be particularly aware of. Somnolescence is common where they have that state of constant drowsiness, falling asleep during the day. REM sleep behavior is important to be aware of and assess for, because this is a challenge for the caregiver, or also this is where the individual is actually acting out their dreams. So there's the risk of inadvertent injury to the individual as well as their caregiver. So we might want to consider on these patients doing the Pittsburgh sleep quality assessment. If there is anything that we can help improve sleep hygiene or whatever condition we're seeing them for, maybe it's their back, is there better positioning we can look at to be aware of this. In terms of behavior for individuals with dementia with Lewy bodies, because it there's a significant behavioral and mood component for these individuals. We need to look more closely at this, especially in the early symptoms, to recognize them. And then it will continue as the disease process, unfortunately, progresses. The individual is going to be afraid, agitated, frustrated. And if we consider that the disease process causes that, and then now they're coming to us for rehab for whatever other injury or condition they may have, this may just amplify it. They're going to become overwhelmed very easily. Maybe we want a quieter environment, see what they respond to. Maybe even get a better sense from their caregiver. They're likely to have different hallucinations, complex, bizarre types of hallucinations, which is the disease process. So if they're talking about things that just don't make sense, that might be the disease process talking. In terms of the apathy and depression component, motivation may be a little bit of a challenge. So we're going to make whatever activities we're working on with that patient engaging for them. So if we're trying to do upper extremity exercise, maybe just dumbbell exercises, that's not going to interest them. Maybe we can somehow, maybe we do a weighted box and it's lifting and moving things that maybe would hold more meaning for that person. May have to get a little creative. And then also bear in mind that any triggers for this individual, they may not be able to communicate or understand what they're feeling, and it may target in more and amplify these mood and behavior symptoms. So, if the individual has a fever or a urinary tract infection, they may not be able to communicate that well, and we may see increases in these behaviors that might give us an idea that something else is going on also. In terms of management, there is some pharmacologic management for the physical symptoms. And then for the psychiatric symptoms for individuals with this condition, unfortunately, it cannot be prevented or cured. It's really just a case of managing the symptoms for in the individual, and unfortunately the cognitive symptoms do worsen over time. That lead to more isolation and sedentary behavior. So we're looking for opportunities to increase that movement and that interaction. The orthostatic hypotension, because it relates to the risk of fall, I want to mention some strategies because it's the autonomic nervous system involvement, elevating the head of bed at night because sleeping's already a challenge, just a little bit, 10 degrees, 9 inches might be enough to decrease the flow to the urinary system, to decrease the production of urine, to hold some of that blood volume for when they first get up in the morning. They might need some compression garments also and referrals for that. When we look at the clinical presentation distinction, Lewy body dementia is the broad category. Dementia with Lewy bodies, dementia as the primary condition is when cognition will be first impaired for the individual, which is what's predominating the disease presentation. Unfortunately, the progression is rapid. The first symptoms are usually some type of hallucinations, and then cognitive impairment usually occurs within a year. And then, unfortunately, within 5 to 10 years, the individual succumbs to the disease process. Um, the hallucinations that the individual experiences are often very threatening, very bizarre, involving animals and people, and this does occur in 80% of the patients. Individuals with Parkinson's disease, where the disease then progresses to the point where the individual is presenting with dementia, they are initially going to present with the motor symptoms. And if we look more closely at that condition, there's actually changes that happen before motor, but it does have a more gradual progression. And the hallucinations for an individual with Parkinson's disease, they tend to be more pleasant. It's family members, it's less common. It's in the later disease process when the individual presents with those hallucinations. And the disease usually progresses over a period of 10 to 15 years before that cognitive impairment is evident. So that clinical presentation, I just put a slide in here to remind us that it's going to start as a motor and then progress to that cognitive presentation for Parkinson's disease. So as we're treating that patient with Parkinson's disease, we're monitoring them for the start of cognitive impairment and trying to be proactive in that sense. The person with dementia with Lewy bodies, we're going to be monitoring them for the motor changes that may occur and then plan for that. In terms of rehabilitation considerations with both of these groups of individuals, we're going to use all the dementia strategies, management strategies that we'll discuss in the last hour for all the conditions we talk about today, Alzheimer's disease and the different types of dementia. I just want to emphasize that fragility is a concern, particularly in individuals with dementia with Lewy bodies. 37% higher incidence of fragility in those individuals compared to individuals who have Alzheimer's disease. Only about 19% of individuals with Alzheimer's disease develop fragility. And fragility is that ability to bounce back after the individual has something minor like a urinary tract infection or a cold. And some of the different contributors to this are the sarcopenia, the loss of that muscle mass, the low level of activity, in addition to the cognitive components. So some studies have looked at how can they help improve muscle mass as well as cognition for individuals with the different forms of dementia with Lewy bodies. And they had them participate in exercise programs that incorporated different types of training. This was a study out of Australia. It was a small cohort of individuals who participated in doing physical exercise, leg presses, tricep pull downs at 80% of their 1 rep maximum. So it was intense for that individual. Then they had them participating not only just in balance training, but adding that cognitive component to the balance training. So they were reaching outside the center of gravity, but while they were holding a cup, so it makes it functional and relatable for that individual. Where they had an image with colored magnets in a pattern, and then as they're doing their balance training, they had to move those magnets to match that particular pattern. And then they did some other activities. And the researchers in this study, I love researchers because often I email them just to ask additional questions. And I'm always surprised, pleasantly surprised at how many get back to me. These researchers actually gave me their data and findings pre publication because it isn't out yet. And they found that those that participated in all of these activities, not only was their function higher and their muscle mass, they found significant improvements in cognition. Specifically, there was improvement in the 6 minute walk test, the chair stand test, BADLs, but then the mini mental status examination, the Parkinson's disease motor scale, as well as non motor scales were improved. So there are lots of benefits here. So we just need to find out how to train at the level for the patient cognitively and physically that we're working with. It doesn't mean we can't challenge them. We're actually seeing in the studies that there are benefits to doing so. The last type of dementia that we will discuss is called frontotemporal dementia. This particular condition is going to involve a group of disorders. There, again, it's a proteinopathy where the proteins are not forming appropriately, specifically in that frontal lobe as well as the temporal lobe for the individual. And the scientists are really just beginning to understand the biological and genetic basis of this disease. I included here several of the different factors they think are contributing. So as the research evolves, you'll be armed with the information to digest it. Ultimately, what happens is there's significant atrophy of the entire brain for the individual. Now, they think the tau proteins play a role because they're finding that the long tubule skeletal formation is not being held, that the microtubular cell division is going to be altered and then altering the transport along that nerve, not only of the signals but of the nutrition and oxygen, everything, blood supply, everything. They're also finding RNA synthesis seems to be altered, and we know RNA is that genetic blueprint that's utilized every time the proteins are replicating to allow the specific neurons and different cells in our body to function. So, the specific protein that allows the neuron to function seems to be giving misinformation. And then granulin. Granulin is supposed to play a role in managing the lysosomes, which break down nerves and help build as well as repair them, looking at that cell survival rate. And there seems to be an impairment there. So when you put all this together, you can see that there would be, diffuse involvement of the brain, and it could present in many different ways. It does affect individuals who are under the age of 60. There does seem to be a family history of presentation. About 40% seem to be genetically linked for individuals. The way the person is going to present, because of everything I just described, there are many different subtypes and presentations. What I want to emphasize is what is common among the four different subtypes. The key here is memory is spared. That's what makes this type of dementia, in terms of clinical presentation, different than the other forms. Memory is spared. So when you're working with these patients, use that to help you with developing your interventions. And again, you may be seeing them because of functional impairment because of their frontotemporal dementia, or you may be seeing them because they fell and now they have an ankle fracture or an ankle sprain. So we need to be mindful of this. Unfortunately, for individuals with all the different subtypes, there's inappropriate social behavior. And part of this is because there's an impairment of empathy. They're not recognizing the emotions in other people from their verbal and nonverbal communication. So they can't, then they're not able to connect to it. So they're not responding appropriately. So what we see is a loss of manners, a loss of decorum, really diminished response to the needs of others. And this is what creates a lot of the caregiver burden for individuals with frontotemporal dementia. In some of the other forms, it's primarily focused on these different behavior variants with disinhibition. These are individuals that you want to be cautious because they're going to be more likely to explore orally inedible objects. There's that hyperorality that's present, biting, eating, chewing, things of that nature. And then there are several other different presentations that I did include here just so that you have that for reference. In terms of rehabilitation considerations, if you're working with someone who has frontotemporal dementia, that inability to change or adjust or just have appropriate behavior and social interactions is a huge component of this disease. And as clinicians and family members, they just have to accept rather than change the behavior. And the way to look at it is it's the disease talking and acting, not the person. This is such a challenge that the Association of Frontotemporal Dementia actually has a 24/7 hotline, live help and support for caregivers and family members to manage this. So we need to be mindful of that. Think about when we're scheduling the person, who else is around. Unfortunately, there are no medications that can help with the progression of this condition, and it does tend to progress. So we're looking at coming up with a regular schedule because of the apathy the individuals present with. We're going to offer choices. Do you want to walk to the bathroom or do you want to walk to the treadmill? Something like that. Looking at supervising the individual, there may need to be changes in the home with locking and avoiding access to food as well as other objects. We're looking at close interactions between speech, OT, and PT, because as language continues to decline for the individual, they might need picture books, communication boards, um, gestures. We're going to try and utilize lists where maybe they point to different words, because remember, they're not going to interpret the nonverbal piece. They're not going to be able to look at a situation and kind of read the vibe, read the emotions. And even if they could, the capacity to empathize is going to be diminished. And then ultimately, unfortunately, function also does become impaired. But remember, memory is intact, so we can use that. We've covered all of the different forms of Alzheimer's disease or forms of dementia, looking at the different clinical presentations. What we'll talk about during this final hour are some of the assessment tools to see the current strengths and opportunities for improvement or impairments of individuals at the different stages of dementia, to help guide our clinical practice and monitor their conditions. We're also going to talk about the different strategies that we can utilize when treating individuals who present with dementia. We'll talk about during this first segment the different types of screening tools. In 2019, the Journal of Geriatric Physical Therapy put out a survey to home care therapists as well as members of their section. And the majority of physical therapists responded that they do feel it is within the scope of practice of clinicians to assess cognition for their patients. However, more than half of those clinicians shared that they didn't feel that they had the necessary skills and knowledge to perform those assessments, which is why I felt it was important to include this as part of the presentation, how to perform and what these different cognitive screens are. Also recognize that, kind of coming back to where we started with the presentation, that earlier recognition of cognitive impairment and appropriate referrals and intervention can help try to preserve some cognitive function, or at least slow the progression. So it's really an opportunity for us as clinicians to help control some of that earlier decline, and then also to help tease out some of those reversible causes of some of the different types of dementia so that they can be treated, and hopefully the person's cognition will improve. When we look at the different types of tools, we're first going to discuss the different types of cognitive screening tools. Then we will look at specific measures of the disease progression and staging for dementia. And then we'll talk about how do we assess pain in someone who has dementia. As we discuss each of these, we need to take into consideration the different cultural influences, language barriers, educational barriers that could be confused with cognition impairment. We need to be aware of that so that we don't think someone's cognitively impaired when really it's just a language barrier, or they don't understand the complexity of the questions being asked because of their educational level, or maybe it's just cultural. And we'll talk about that as we work our way through these different tools. First is your basic clock draw test. We're all doing this already. It's one of the simplest kind of command or command and copy type of tools that is utilized. The research says that this is less affected by culture, education, and language. I would say, I think moving forward in the future, I'll be long retired, but many of you will still be practicing. I don't know how many elementary schoolers and high schoolers right now know how to read a regular clock. But that's just me thinking way too far ahead. So anyway, the clock draw test is going to ask the individual. You can start them with the circle or not on the paper. So you're going to ask them to draw a clock, and then you're going to set the hands so that the clock is going to read in this example 2:30, and you're going to look at the individual drawing the clock. The first example is how it should look for someone who does not have any impairments. The second example is someone who has mild cognitive impairment. This would be the individual who they were able to pretty much get the numbers around there. Spacing isn't great, but it definitely resembles a clock. It has the right numbers. But what happened is when it came time to draw the hands, they had forgotten what time they were supposed to draw. And then on the far right, this is someone who has Alzheimer's disease, where it doesn't even resemble a clock. Spatially, the number orientation, there's no time. Um, so it has little resemblance. Oh, sorry, Alzheimer's disease, just to give you an example there. When we look at someone performing this, the cognitive domains that this simple test examines is looking at attention, um, auditory comprehension. So we need to make sure that the person actually heard what it is, executive functioning, because they have to plan, sequence, organize, visual spatial to put things in the right order and space them equally. It's semantic memory, because it's what is a clock, that's something that we just know. But then it's also that working memory, because they have to remember what time they were supposed to do as they're completing the other task. The other way to look at this test is, I don't just consider it as product oriented, it's process that we can also look at. So as the individual is drawing the clock, look at what is going on. So, do they have a pull to stimulus? So, let's say you told them to set the hands to 10 minutes after 11, and so they drew the hands like this. They drew it between 10 and 11 because they remembered that, but they couldn't organize 10 minutes after 11 and correlate that to a time. Is the individual perseverating? Are they drawing, the same thing over and over at the same location? Is there looking at that spatial awareness? Now we know if it was all on one side, we'd be looking at some type of neglect, but in general, look at the individual's spatial awareness. So there's different ways to look at this test, and they're coming up with actual digital versions with electronic pens that can read some of more about the process to give us more information from this basic test. So you'll see that coming in the future to look at more of that working memory and speed of processing. The memory impairment screen, this particular tool is going to be a quick measure. The individual is going to be given four different items, and they're just going to recall what they are. This is a little different than your basic recall test, because for each item, you're going to give a category. And then when you score the test, there's going to be free recall. Can they just tell you what it is? And then you can prompt them with the category and then see if they remember what the item is. So the way you set up this test is, the recommendation is to use a 24 font on a piece of paper to type out the four items. So the four items I'm giving you are checkers, saucer, telegram, and red cross. Then you're going to distract the person, for about 3 minutes, and then see if they can remember them. Ready, go. um, so you're going to see what they now. When you initially set up the test, in between that, you're going to give them the words, you're going to have them read them, make sure they know them, and then you're going to tell them a category for each. So I'm going to say checkers is a game, saucer is a dish, telegram is a message, red cross organization. And then you give them those cues if they need it during that recall, and you score the test out. The threshold is less than four items recalled out of the eight, with the two different prompt and no prompt category, that the person should have a full cognitive examination. Now, the research says that there's little or no educational bias on this test or culture or language. I am not disagreeing with the research. However, what I experience is that, do we use saucers anymore? Depending on the age of the person, have they even heard the word telegram other than maybe in an old Western movie? Red Cross, okay, in Florida, Red Cross is here a lot. We have hurricanes, but other parts of the country, does that hold any meaning? So I don't know. You might want to consider the words that you're using. Would something like factory is a kind of building, toothbrush is a personal item, math, school subject, policeman, city employee. I don't know. Maybe you just want to think about that. This test does not examine working memory, it does not examine visual spatial. It's just a quick basic test to give you some information, but I think this is going to help us in giving our commands, our queuing complexity. Do we need to also give written instructions for more of what we're doing? Do we need to be monitoring that patient more during their exercise because maybe they're going to forget what they're supposed to be doing? So you'll use this information different ways. The Montreal Cognitive Assessment, this particular tool is more comprehensive. This is more involved. It is still a rapid screening in general for different types of cognitive dysfunction. And it's on many different domains for the individual. And it's going to give us more insights in distinguishing the diagnosis and more insight in how the individual's tasks outside of the clinic may be impacted and how we should be communicating and interacting with them while they're in the clinic. To show us this assessment tool that is this is an on paper one. So in the first portion, visual spatial, they're going to have to connect A to 1, then B to 2, C to 3, draw a box. It does incorporate the clock drawing test for that individual. It's going to give them pictures of animals and just ask them, can they name that particular animal? Another part of the test, looking at memory, they'll be given a word list and then see about the delayed recall for the individual. When we look at the scoring of this testing, because you're going to do two trials of it, for the delayed recall, we're looking at a score threshold of 7 to 8 as our cutoff, where they may need more full evaluation and where that is more likely someone who has dementia. You're going to ask the individual, how many words can you name that start with the letter F? If you're going through your list now, I'll be quiet. How many words to start with the letter F? And then the threshold for that naming part of language is 11, is what you should be able to come up with that starts with a single letter. In terms of attention, you're going to tell the person, well, every time I say the letter A, I want you to tap, assuming that's within their function, based on what you're seeing them for. So you're going to say CDALNAPAQRZA, and then see if they can follow with that. So that's going to let you know, can they stick with something, and can they hold on to it, that working memory. And then there are some other components to the test also. And to give you a little idea that you can see how that would give you a lot of relevant information for planning and sequencing, and then even for education at home, how to maybe modify activities and group complexity and how long different tasks are. When we look at different cutoffs overall for the scoring of this particular tool, someone with a score of greater than or equal to 26, this is going to be considered normal. The scoring does have an adaptation in the calculation there. If someone's educational level is under 12 years of education, formal education, but 26 is considered our normal score. So below a score of 26 is what they're saying is that cutoff for mild cognitive impairment, and it has 100% sensitivity but a low specificity. By the time you get to a score of less than or equal to 22 as your cutoff, the research says that this still holds a good sensitivity and specificity for that presence of cognitive impairment for the individual. So I would say someone who's in between a 22 and a 26, those are the individuals where we have concerns over that mild cognitive impairment as an overall score, and we want to be referring that patient out. Mini mental state examination and the mini cognitive assessment. Um, these tools cannot be utilized, just to preface for all of them, to diagnose Alzheimer's disease or to diagnose dementia. We're utilizing these to identify the cognitive strengths and limitations of the individual for our planning. So you're probably going to use several different assessment tools to gather the most information to help guide your interventions. Also, bear in mind that as you're working with these different tools, you need to space out your implementation of them based on the other impairments the patient has. You don't want them to become agitated or overwhelmed as you do these different assessments. So, the mini mental state examination, the MMSE, this particular tool is going to ask the individual certain questions, and then it is going to be scored out. So for example, it has your basic orientation to what's the year, season, date, etc. Where are you? Then it goes into counting backwards by 100. What this tool adds that I think provides some benefit is you're going to show the individual two simple objects. So maybe you show them a watch and a pencil, and you're going to ask them to name it. So this might help you see that patient that has that agnosia that's not recognizing different objects. You're going to ask the individual just to repeat a phrase back to you. To see if they're able to accomplish that. And then also looking at the individual's ability to follow commands. This particular tool gives us the opportunity to look very specifically at that. So you're going to give the individual a piece of paper and you're going to tell them, I want you to place this paper in your right hand, fold it in half, and put it on the floor. So you give them a verbal command, see if they're able to execute that. Then you give them a different piece of paper and you write instructions on it. So you're going to tell them, I want you to crumple this paper up and throw it. I don't know, whatever you choose, with something that would make sense to them. And then you're able to see if they're able to interpret that written language and then follow through with it. So it'll give you more information. And then it has some other assessments in there. But if you're looking at how to cue the patient, that would probably give you more feedback. Someone between a 20 and a 24 has a mild impairment, 13 to 20 is moderate, and then an individual with a score of less than 12, that's where we're looking at a severe impairment. Something to be aware of with this test is that if you're doing it for ongoing monitoring of an individual with Alzheimer's disease, regardless of where they're starting, the estimate is that you'll see a decline of about 2 to 4 points per year of their functioning on this test. And that might be something if you're implementing an exercise program and following up with the person, well, maybe you get to see if there's benefits. Do your own little research there. Also, they're saying that this particular test does have a ceiling effect. So, someone who has a high education level, high language with them, high cognitive abilities, that's highly educated, they can still be impaired and do well on this test. So, be aware of that. This test also does have language, education, and cultural biases that we need to tease out. The mini cognitive assessment, this is a different tool. This is looking at the individual's ability to recall objects and then do that clock drawing test. So you're just going to give them common objects. Let's see, banana, sunshine, chair. Wait, see if they can recall it. The threshold for that is if the individual scores on this test less than or equal to a 3, then this is someone who needs a full evaluation. Looking now at staging of individuals with dementia, the functional assessment staging scale, it's called the FAST scale. I just put kind of like a summary here of the categories. There is a lot more to the tool. It's much more descriptive. And again, for all these tools, I do have links to them at the end of your course notes package. This school is looking at, it really helps in planning for the individual to meet their needs, looking at palliative intervention and care planning for someone who's more in the advanced stages of dementia. um, the way you're going to score it out is you're going to look at the individual's ability to function, and you look at like the highest consecutive level. Let's say the individual, they're unable to work, so they can't work, they can't do complex tasks, and when they dress themselves, they're layering their clothes. That when they put those clothes on, they're layering them. So they're going to get a score of 6 because they're able to dress themselves, but then actually putting on those clothes is where they're at. So that's our score of 6. And then let's say they also happen to be incontinent of urine. So that's not consecutive. So we leave them with the 6, and then we add a point 2 because they're also incontinent of urine. So they end up with a score of 6.2. This particular tool is utilized by CMS. The threshold score is a 7 for an individual who has less than 6 months of life left. And look, I even struggle to say that. It's sad, very sad to think about. But the plus here is that it does help in planning, and this tool is utilized to get that person and their family access to services. And this is what is helped to utilize to have someone become eligible for hospice services. So it's going to help with your goal setting and help with you to maintain quality of life as much as possible and get the services someone needs. deterioration scale. This scale is going to look at individuals at the different stages of cognitive decline with Alzheimer's disease and the other forms of dementia, and it's reflecting how it impacts their ability to function in their life. Again, good help with goal setting. So, a stage one is someone who does not have any specific cognitive decline. This particular tool, just to give you an idea, it asks manifestations or clear cut deficits the person has. So, one of the choices is patient may read a passage of a book and retain very little of the material. That would be someone with a mild cognitive impairment. Then another question is, looking at your clinical review, someone who has a concentration deficit that's elicited by serial subtractions. They can't control that. So that would be someone who has mild cognitive impairment moving towards dementia in that stage three. And then it correlates to the different types of dementia and memory and cognitive impairment that we've discussed. What I want to highlight as you work through this tool is bear in mind that the research shows that about 50% of the individuals in stage three are going to have some type of psychiatric symptom associated with it. As individuals seem to move between stages four to five, in this transition, you're going to see that there is decrease in or an increase in disorientation for that individual. They're going to get lost more. And as someone goes from a stage five to stage six, that's where we're significantly going to see agitation increase. And I think it's important for us to know what's next so we can participate in planning. Pain assessment for individuals who present with dementia is very, very important because their ability to communicate it or even recognize it to communicate is going to be impaired. So we need to bear that in mind. We don't want the person to be in pain or uncomfortable. Maybe they have a bowel obstruction. Maybe they need to go to the bathroom. Maybe that rotator cuff is bothering them or they have a migraine, whatever it may be. So the recommendations from CMS is what I base this slide on. And again, we need to distinguish pain from delirium based on what we discussed before. The Iowa pain thermometer is one of the tools that is recommended. This you're going to show to the individual, and they're going to be able to rate their pain. It is not recommended that we use that straight visual analog scale. A colored visual analog scale could be utilized, but the pain thermometer is more recommended. If we look at when should we use what tool? Someone who has a mini mental state exam score of greater than or equal to 14, that individual should be able to give valid responses on the different thermometer tests as well as the box test. Someone whose score is going to be less than a 12, that individual is not going to be able to effectively relay their pain. So, what you're going to utilize is the pain AD scale. And what this stands for is the pain assessment in advanced dementia. So, this particular tool, it helps you utilize nonverbal communication as well as verbal or auditory sounds the individual makes to help recognize if they're in pain. And this is something to educate the family in as well as to utilize ourselves. It looks at many different aspects. So, for example, you're going to look at the individual's breathing. Does it look labored or are they hyperventilating? Vocalization, in terms of negative vocalization, is their speech just really low or is what they're saying just not being said in a nice way? Are they moaning, crying, those signs of more intense pain? Looking at the individual's facial expression, do they look frightened or scared, or that might be a low level pain versus someone who's actually wrenching with their face is in a higher level pain. Examining the individual's body language. If someone's fidgeting a lot or they just seem tense or they're pacing and distressed versus someone who's become really rigid and tight, maybe they're lashing out physically, holding their legs, that's a higher level pain. Are you able to console them? Someone who could just be distracted when they're evidencing these things, reassured with voice or touch, maybe it's a low level pain. Someone who is just unable to be consoled might be a higher level pain. So it's a scoring mechanism that you are going to utilize to help determine the level of pain that individual's in, and then assess what is going on. Do we need to teach to modify sleep position? Is it an orthopedic pathology? Is it, I don't know, maybe the little toe part on their sock is cutting in for them. Maybe they're feeling that pressure because they haven't moved in a while and we need to do a position change. So all of these different things to consider. Some other rehab considerations is not to forget the family. This is important because the family or caregiver, I should say, it is a lot for them to deal with. If we're looking at like what activities to do in therapy, we want to keep the patient part of it as long as possible and involve them in the decision making. If they can still communicate, what are they having difficulty with? What's a priority for that individual? Just like we do with all of our other patients. The individual still has likes and dislikes, even if they can't communicate them, even if they may not necessarily remember what they are. If we can find that out through the family and somehow incorporate that into rehab, it's going to increase participation. It's going to make them less apathetic. Maybe we're going to pull in on that semantic memory a little bit more, to make things more enjoyable and accomplish the goals that we are trying to work on. As we look at physically, we're working on balance training, or we're working on, obstacle courses to navigate the environment. Again, we may not be treating this person for dementia. It may be a comorbidity they have. Either way, what we need to keep in mind is there are going to be visual impairments. We looked at all the different brain areas that are affected. And what they found that tends to happen is when we look at the field of vision for someone who is presenting with dementia, it tends to narrow to about 12 inches peripheral. So that means, in terms of their scanning to be, reactive and anticipatory, it's going to be decreased combined with whatever deficits they may have. Bear that in mind. Also, look at the ability for 3D vision, that visual spatial relationship becomes impaired. So the individual may look at this patterned carpet on the right and change my ink color. This big blue circle, is that a hole that I'm going to fall into? Are these big white things I should step on them? I shouldn't step on them? That could be scary. That could be agitating. And it's a change of environment. You're in a hotel where you're usually not. We need to think of these things. Looking at these kind of like shiny spots on this pattern and the dark spots on the floor. Well, is that something that I need to pick up? Maybe the person's falling over because they think that's something that fell on the floor that they need to pick up. They don't know that it's a pattern. If you're looking at that placemat that the person's eating on and it has pretty flowers or an apple or whatever it is, well, maybe they're trying to pick up that apple to eat it. That could be frustrating and confusing for that individual. So there are a lot of different brain areas that are impacted that we have to keep this in mind. Also, just for sitting on a chair, we need to look at that color contrast because that depth perception is off. Are they going to know how high or how low something is to control their sitting? So bear these things in mind for in the clinic as well as outside of the clinic. When we look at, again, physical activity, we're going to look at increasing physical activity for that individual just for those helps, those cognitive benefits. Also consider when you're looking at doing physical activity, whatever types of equipment that you're using, if the individual's depth perception is off, they may not know how far away something is in terms of safety with using different objects. And also just think of in their general interaction in their environment, they may be trying to reach for that light switch, but it's too far away. So they're trying to, turn it on and off, but they haven't even gotten to it yet. So you're going to look at incorporating that and seeing if maybe that's some of the challenges that that individual is presenting with. And all of this comes down to improving the functional training for the individual. When we look at the different types of memory that are called upon for our functional activities, we have implicit memory and then we have explicit memory. Our implicit memory is our procedural memory. So it's the how to. So that individual, if we look at doing a transfer, they may know how to do that transfer. Initially, this is going to be less impaired in someone. We're going to rely on this in rehab that they're going to know how to do certain basic tasks and then incorporate that as we're trying to teach them to do new things. So let's say we need to work on their balance and we want to do some type of balance challenge for that individual. The typical things that we do with, using tape to create patterns, or different strategies with, changing different stances and reaching for things, that may not hold meaning for that person, and their ability to learn new things may be struggling. So maybe instead, if they remember how to sit down and stand up, maybe you place different chairs around different areas, and what's your task? Sit down in that chair, and they had to navigate to get there. And you set things up so it went through those different movement patterns that you want them to work on, because that's going to, you use that implicit memory a little bit more so you can build on it to learn new motor skills, versus that episodic memory is that explicit, that's that conscious recall of things. If you ask them, what are, okay, so tell me the steps that you're going to do to stand up, they might be able to do that, but they're not going to remember those personal facts, those personal events. So if you're saying, okay, remember last session, this is how we did it, that's not going to help them. So we're going to focus on feedback on the goal, not necessarily on the movements or activities they're doing themselves. So a lot of patients, how we're, going to, sit up straight, pull your shoulders back. Okay, you feel that muscle working. Good. We got good scapular retraction. That's not going to necessarily work with this individual who has different stages of dementia. We're going to work on feedback of the actual activity. So remember, we're looking up, right, to get them to stand up and get those shoulders back, or, look, versus those other types of cueing. Also, whenever possible, we want to replicate performance. So use words and images to tap in for the individual that keep it simple. So if we are increasing balance, for that person to be able to get something in and out of the draw, maybe on our little table in the clinic, we tape this on, and we have a box there that they're reaching for if we didn't pick up a cheap little inexpensive dresser somewhere and throw it in our clinic. And then at home they have this same side in the same location for that carryover. Also, the research has shown that parallel cues work better. Often we do our demonstrations in front of the patient so they can kind of see the whole thing. But with individuals with dementia, parallel cues work better. So you might need to have someone else demonstrating doing that movement pattern at the same time, because again, that's goal oriented. You're not giving them all those verbal and tactile type of cues. So replicate that performance environment too. Spaced retrieval technique, this is a specific strategy that can be utilized when the person needs to work to remember specific important information. It's a compensatory skill. It probably is used a little bit more by occupational therapy, so I can feel the head nods. Out in the audience, but it's something that we can incorporate as physical therapists also, and assistance for both. So this spaced retrieval technique is going to help with that acquisition of new information. It's worst based on errorless learning because they won't progress until it's correct. Here's an example. Let's say the individual needs to remember to lock their wheelchair brakes before standing up. So you've educated them, you've taught them, you've done your parallel imaging and all your different strategies. And what you're going to say is, okay, what do you have to do before you stand up? They should say, lock the wheelchair. If they do, great. You go on, you distract them, you do something else for, 3 minutes, you ask them again. They still remember? Beautiful. You keep increasing your time for them to remember it. Let's say it's incorrect. If they couldn't state the information correctly, then what you're going to do is tell them the correct answer, use the same brief, quick, terminology every time. And then you're going to give them a visual cue. So maybe they're sitting in the wheelchair and you're going to say, look, lock the wheelchair. Tell them, lock the wheelchair. And they lock the wheelchair. Then you're going to go back and redo this again and again. And the idea is that that kind of repetition is getting it into their memory, and it's errorless. So they're not going to be trained on the inappropriate technique. It can be utilized to remember facts, birthdays, things like that. You can also utilize this as a quick screening tool to see if this strategy will work. So what you might do is give the person your name. So you introduced yourself, and then 30 seconds later, see if they remember your name. I am very bad with that. I need to work on it. But, so something like that to see if this might work for the individual. Patient caregiver education, what we are going to consider related to this, it's multifaceted. We have lots of opportunities. The CDC has many different resources that I provided links to at the end of the course notes packet. Manage the comorbidities, emergency preparedness. Think about medication management, urinary tract infections, constipation, all these different needs of the individual beyond the obvious. Financial exploitation, I want to highlight because there is a specific website from the Office of Financial Protection for Older Americans. It's stopfraud.gov to stop that financial exploitation. Maybe that's just a poster you have up somewhere or part of your packet you give out to your patients and caregivers. Remember that we do need to think about the social stigma for the individual as well as the caregiver's health and well-being. There's a study that was recently recruiting that looked at the interactions between the caregiver and the individual that has dementia, and they found that when things get strange, we are all human, that those negative communications negatively impact the individual with dementia, as well as creating a lot of stress for the caregiver. So they are finding that that emotional over involvement sometimes has a negative effect for both individuals and leads to more criticism. So this study was looking at, I haven't seen the results yet. Having the caregiver participate in more mindfulness training for themselves to see if that will help decrease their stress, decrease their burnout. And then their anticipation is that this will translate into less reactivity. It'll contribute to better awareness in order to help the person they're caregiving for. So I just thought that was nice, something else for us to consider as we're looking at program development. In terms of supplements, the FDA has a statement out that says, I'm going to read it specifically, be cautious about false cures. Currently, no product will prevent dementia. And individuals should be referred to the physician to discuss. So while there are some studies that are showing maybe cat's claw or polyphenols may be helpful, the FDA is saying that the research is not there yet for any of those specifically. As we examine our different communication strategies to help improve our communication, there are those basic do's and don'ts that we're already aware of, and it's good to remind ourselves. Open ended questions make it difficult for the individual. So, our typical, hey, what'd you do over the weekend? Not a good idea because it's asking the individual to remember something. We don't want to remind the individual of losses. So if they're saying, who are you? Where's my husband? When are they coming back? Maybe we're just going to say, oh, he'll be here later, and let's go do this now. How about we go for a walk? Try to distract the individual. Don't scold or insist on things, corrections or reminders that they don't know information. The do's are slow things down, give the individual time to comprehend, don't rush. And this goes with planning and sequencing of activities, getting ready for appointments. Us just on our schedule, we're human too, to bear in mind they need more time. And keep our cues simple, brief, and always use the same words every time. We're going to keep our eye contact with the person, try to use our gestures as much as possible during the time when they can still interpret them. And then physical contact, holding a hand might be good, might be reassuring. Agitation, there's a shift in the perspective related to agitation. We should think of it as an unmet need or a lack of understanding. That the estimates say 90% of the patients with dementia are going to present with agitation at different points in time. And the definition of this is inappropriate verbal or some type of vocal or motor activity, not aggressive. But it can happen, and they're finding an association between individuals with dementia who are more sedentary to having greater levels of agitation. That activity somehow, particularly outside, if possible, later in the day, seems to decrease the amount of agitation the individual experiences. And the time of day that they found most often individuals are sedentary is in the morning. So maybe that's the time to schedule someone for their therapy session as you're building their day. There were a couple interesting studies that looked at horticulture, um, and as a method of engagement, and it connects the person with nature. It's multisensory. It may pull into those good feelings and previous activities. It might be a fun way to teach a new skill for someone. Motor tasks. We weight things. We place them at certain distances to incorporate what we're really trying to work on, and it's a way to connect with their caregiver. Music therapy has also been found to be beneficial for individuals that may actually have an immediate symptom reduction for agitation. Hallucinations that someone experiences. A hallucination is hearing, seeing, smelling, or feeling things that are not really there. So maybe children playing in the other room. A delusion is the false belief that they think something is real. So, individuals who present with this, we don't want to argue with them. We want to let them know that they're safe. Think about if the individual has the TV on or we have music on in the clinic. Could it trigger some of these hallucinations or delusions? Do they think whatever it is really happening? Is it increasing their fear? An individual who presents with paranoia, this is when they think that someone's out to get them, people are stealing their objects. It's important not to react to this. Again, let the person know that they're safe. Sometimes distraction is enough, or sometimes just saying, you know what, I did move that piece of jewelry. I was afraid someone else was going to take it, so I put it in a safe place for you. Here it is. This might be a strategy that can help work. And then distraction can utilize pictures, engagement, keepsakes, things that make the person feel good can help limit this. risk reduction strategies, as we think about safety, we need to remember simplifying the home. Remember that visual spatial. This floor, am I stepping on those things? Not stepping on them? It could be very overwhelming. We do want high contrast, but in a functionally appropriate way. Maybe we're using a colored toilet seat or an edge, colored something on the edge of where the sink is. We also don't want it to be monochromatic. That's not going to help with the depth perception of reeling which is the toilet, which is the sink, which is the bathtub. Um, One strategy is to color match and create signs to get to places. So I have a picture of a toilet, it's colored blue, blue for water for the toilet. Maybe these signs are at eye level if they're in a wheelchair or standing. Down the hallway to get to the bathroom, maybe I painted the door blue. Maybe the toilet seat is blue. So all of that is reinforcing. Going into the kitchen, you can use different signs to label where the different rooms are located and then color coordinate those signs with the specific room. In terms of vestibular assessment, this is something you want to look at incorporating for your patients who have Alzheimer's disease. Individuals with that tend to have a 2 times greater not risk. It just tends to be 2 times more common that there is hypofunctioning of the vestibular system in an individual with Alzheimer's disease compared to someone who is cognitively intact. Safety, we know, is very important. We want to look at how can we keep the person safe. When we're making our different signs, don't make them shiny because it may look wet. Don't have super shiny things on the floor. They may think that that is wet and they're going to slip. The individual is going to have difficulty interpreting what they're seeing. So look at lighting, look at mirrors, like I said, shiny things on the floor may be confusing. Maybe signs that say out of order, broken, closed could be helpful for safety. Keep chemicals, perfumes, cosmetics, anything that the person may put in their mouth and mistake for food, keep those out of the way. Sundowning is specifically due to a disruption in their circadian rhythms that become dysfunctional when there's neurodegeneration. The sleep wake cycle is mistimed, and symptoms tend to increase for the individual of that restlessness, agitation in the evening when it starts to get dark. So, ways to try and help minimize that. One thing that may seem counterintuitive is you're going to close the blinds and turn up the lighting because this helps decrease shadows, and those can be triggers or scary or more confusing for the individual. Having a set routine is very important. So, maybe there's a snack, a simple task like folding the laundry. If the person is experiencing sundown, listening to their concerns. Maybe that's the time of day where the family schedules the call with the grandchild, something the person's looking forward to that might be calming for that individual. If the individual tends to be getting more tired in the afternoon, not the time for a nap because that'll contribute to increased sundowning. That may be the time to actually put that exercise into place. Increase lighting, get them outside to help minimize some of this sundowning to cue their circadian rhythms a little bit better. want to do that, there's an increased risk of wandering with sundowning, and wandering is a safety concern regardless. This is when the individual is leaving the safe area, or the responsible caregiver or person who's with them. We're concerned about falls, getting lost, injury, victimization for the individual. Tends to happen more when the individual is disoriented or agitated, or just in crowds when they're overwhelmed or in a different environment and overstimulated. Light, noise, temperature are triggers. That's why around the holidays, all those things kind of come into play. Everything's out of order, so we have to be careful. Also, again, there's a shift that wandering may be due to an unmet need. Does the person, are they hungry? Are they thirsty? Are they in pain? Do they have to go to the bathroom? All of these different things to consider. There are different alert programs that are available. Also, there are is a suggestion that you should keep a piece of the person's clothes in a sealed Ziploc bag with their scent on it, in case that was ever needed. Hopefully not. Some other strategies to limit wandering. We want the person to not be encouraged to leave. And when we look at limiting wandering, we want all of those signs of departure to leave. We don't want the keys hanging right by the door, the hat right by the door, any cues that would say, hey, yeah, this is where you go to get out. There are those high tech strategies of GPS and different things, but low tech is good too. That's important in our facilities as well as in the home environment, to mitigate the risk of the person attempting to leave. Using the doorknob locks that, twist so it doesn't actually turn, we have to be careful for an emergency. Those should only be used when someone is around in case there was a fire or a need to evacuate. Putting push instead of pull on a handle. Some other more creative strategies that are visually appealing are to not make it look like there's an exit door. Paint a mural over the door. Use some of that visual perceptual deficit. So, out on the far right here, have a big mat here that's a solid color. Maybe the person thinks that's a hole. Oh, maybe I shouldn't go out that way. Have pleasing pictures of family members based on the stage of the disease that are going to grab the person's attention by the door so they get distracted about trying to leave. Then having a secondary barrier. So if the person did get outside, maybe there are bushes planted around or something else to engage their attention so that they do not continue with their attempts to leave. There was one study in a facility where they utilized the murals, hanging curtains across a door so it doesn't look, it looks like a window, not a door. Creating it, make it look like a dead end. So maybe whatever color the paint wall is, you hang a curtain that same color so it doesn't look like it goes anywhere, or paint the door the same color. They looked at using these different strategies, and they found out that in this particular cohort, they decreased by 50% the number of attempts to leave, and 40% of the attempts were not successful. So, the different strategies that you can use are the distraction strategies or the full stop strategies. Like, this isn't a real way to get out, or hey, let's put your mind someplace else so you don't want to leave. And then, of course, making sure the needs of the person are met. forward, what they're looking at is earlier diagnosis in the emerging research as they look at the amyloid and some other factors. They need to cross the blood brain barrier if it's going to be able to be checked in a blood test. And they are finding that some of these different biomarkers do end up passing the blood brain barrier. Particularly, they're getting into the spinal cord, into the cerebrospinal fluid, where they're able to check for the amyloids, for example. So they're looking at some different tests to examine that earlier. They're finding for the different forms of dementia, as the imaging on the right here shows, that there will be deterioration in different regions of the brain that lead to the different clinical presentation. So they're looking at different imaging studies to distinguish these different i- types of dementia. Something relevant to us directly that might hold value if you just start paying attention to it yourselves, or something to look at when we're training. Specifically, researchers were examining gait analysis and then looking at individuals who went on to develop Alzheimer's disease. It was a pretty large cohort study of 500 participants who were between the ages of 50 and 95. They followed them for 2.5 to 3.5 years. Every 4 months, they did follow ups with cognitive assessments, gait analysis. They looked back to see the relationship between gait and who went on to develop which types of dementia and who didn't. And they actually found changes in gait years and years ahead of when the person developed different forms of dementia. And they found specific gait deviations. How do we want to use this information? I don't know. It was interesting, but my thought is, obviously, when we look at dual tasking and rehabbing any patient for any condition, we want to get back to a normal gait cycle. But maybe just being aware of certain components of gait that are shifted in individuals with certain types of dementia. Maybe, the research is showing, and we're doing a cognitive assessment and we're putting all the pieces of the puzzle together. Maybe this will give us more insight. So we included here the different gait deviations and the different dual tasking that the individuals have difficulty with, because it might also help us in goal setting that we don't want to see these deviations or these challenges. So maybe it'll help show us with everything we're putting together, maybe there'll be a little more preservation of that cognitive ability. Future research is looking at ways to preserve that cognitive function, or at least slow that decline for individuals by diagnosing earlier, increasing physical activity, controlling comorbidities, and then that cognitive training. Build that cognitive reserve as much as possible. And as clinicians, we want to use these opportunities as much as we can, and they're trying to look at different ranges of populations to gather more information in these areas. What we discussed today about understanding the differences in the types of dementia and cognitive decline, the physiologic presentations, arms you with the information that you need to examine the future research. And then we also looked at specific strategies when we're working with our patients with different types of cognitive impairments, how we can help enhance our communication and outcomes for those individuals. How many different types of dementia are there? That's a very good question. When we look at how the physicians classify and diagnose different diseases, there are several specific guidebooks that they utilize, the ICD 11 and then the DSM 5. The ICD 11, we're all familiar with, that this is produced by the World Health Organization, who has a public health mission. And the ICD 11 categories human diseases, medical conditions, as well as mental health disorders, which is where dementia falls. The way that they categorize the different types is looking at mild neurocognitive disorder, where it goes beyond the impairments that we can see or typically expect for someone related to aging. They're going to have impact in one or more cognitive domains, and it does not interfere with the individual's ability to function. So they're able to personally, socially, educationally, occupationally function still. The other category are the major disorders, where they're looking at marked impairment or two or more of those neurocognitive domains. Memory tends to be more primarily affected, but then also executive function, attention, language, social cognition and judgment, visual, perceptual, everything that we talked about. And in this case, it is affecting the individual's ability to function. And then they have different specifiers related to them. To try and give you a little bit of a number, we would look more at the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. So, this is produced by the American Psychiatric Association and is the handbook that's utilized by professionals in the United States to diagnose different mental disorders. So, again, they categorize based on major and mild neurocognitive disorders, and they're looking at the way they classify them, whether it's due to Alzheimer's disease, frontotemporal, Lewy body disease, vascular, substance abuse, Parkinson's disease, and several other categories. And then they recently added the classification of it's possibly due to one of those diseases. So we can kind of already see that the number of types of dementia is expanding. And then they further go into specifiers and subtypes based on severity, how much ADLs and work and function are impacted, if anxiety is a component, mood, different types of behavioral or psychological impacts. If we I just loosely run the math on all of those different categories and classifications, there are almost 13 different dementias with associated etiologies, and then when you consider all the subtypes and specifiers, it gets up to probably over 120 different classifications of diagnosis. So there is a lot for the physician to tease out in order to assign the right diagnosis. Why do caregivers share memory and affect changes in their family member who has a UTI? The distinguishing those memory changes and affect changes from dementia is important in older individuals. And part of the challenge is that the urinary tract infection in some cases may not have many physical symptoms, or the individual may not be able to effectively communicate if they are having those symptoms. The Oftentimes it's also the last thing that family members may be considering as a cause for those personality or thinking changes that they're seeing. So sometimes they call it a silent UTI, where the only observable change is in behavior for the individual that the family and friends are noticing. The individual may not be having any pain, burning, odor. They may not be having frequency. So there are really just those behavior changes. And some of the proposed reason for that is that the brain is more affected by the inflammation from the infection, or the stress hormones that the body produces to fight the infection are somehow contributing to those behavioral changes and affect the inflammation and stress on the brain, leading to that delirium for the individual, that kind of restlessness. Also, they may have weakness and fatigue, and oftentimes those around the person may think it's an onset of dementia. The difference is Dementia is typically progressing more slowly in its early stages, and the delirium that an individual presents with for the UTI tends to have more of a sudden onset, that kind of fluctuation in mental functioning, and it's usually reversible with appropriate treatment. Something else to consider is that if an individual has dementia, and then they develop a urinary tract infection that they might not be able to communicate, and they are at greater risk for developing those because they may not have as much awareness of their body and hygiene. So as the disease progresses, the dementia, they may have a urinary tract infection develop, and then you have that delirium superimposed on top of the other signs of dementia. And of course, we don't want anyone to be uncomfortable in going through that pain that they may not be able to perceive or explain from the urinary tract infection. And it is important then for family members and clinicians to work to distinguish those for the appropriate intervention. Is dysautonomia associated with dementia? Dysautonomias are malfunctions of that autonomic nervous system that can happen for many different reasons. Primary dysautonomias occur due to either a genetic or a degenerative disease that affect that brain and nervous system. And then the secondary form results from some type of injury or other condition. Autonomic dysfunction has been shown in individuals with Alzheimer's disease that we discuss. Also, the different types of Lewy body dementias, dementia with Lewy bodies, or Parkinson's disease dementia. And those symptoms that we'll see are related to that autonomic system dysfunction. Orthostatic hypotension, syncope, potentially leading to falls, different urinary tract symptoms, as well as constipation. So, those non motor components of the Parkinson's disease and the dementia with Lewy bodies are important to consider uh, when you're looking at managing the dementia, but then also managing those other non motor symptoms that are related to the autonomic dysfunction. How would you describe the difference between dementia and Alzheimer's dementia? That is a good and important distinction to make. And it's a little bit difficult to answer, and it's probably going to sound like a lot of circular talk. But dementia, by definition, is it's a symptom of whatever the disease process is. It's not its own disease. It's more that general term for impaired ability to remember, think, make decisions that interferes with the individual's activities. So if we compare that to normal aging, then normal aging, we're going to see, occasionally misplacing the car keys, maybe forgetting the name of, an old acquaintance. It takes you a little bit to pull that up. Um, so the person with normal aging is going to, retain their old memories. Language is going to stay intact. Dementia, on the other hand, as just a general condition, we're going to see that impairment in all the different neurocognitive domains, different um, aspects of it. And then that would depend on what other disease process is causing that. So, Alzheimer's dementia is really Alzheimer's disease, and one of the symptoms of it is dementia, along with the other components that we see. So sorry, it's not a simple answer, but the easiest way to say it is that dementia is a clinical presentation of Alzheimer's disease as well as other conditions. Is someone with ADHD at greater risk of developing dementia? I will preface this with saying I am not a physician, cannot diagnose. From the research that I examined to create this course, I'll just give you a little bit of background on how the different association is being explored. What they're looking at related to attention deficit hyperactivity disorder, it is not saying that it directly causes Alzheimer's disease or other forms of dementia. The research also says there isn't a lot of research, not a lot of studies are looking at this across broad populations and long term studies. With ADHD, we're looking at an individual's chemistry of dopamine, the neurotransmitter responsible for movement and mood, norepinephrine, the neurotransmitter that's responsible for that fight or flight response. Um, Whereas with Alzheimer's disease, we're looking at more of a neurocognitive or neurodegenerative, I should say, type of condition that we looked at how there's actual loss of the neurons in the brain that impact the communication. So there are two different disease processes based on what we know now. There are a couple of studies that looked at the relationship that I did come across. Did not do it. I did not do an exhaustive search related to this, but just to mention a couple that may give you a little background on why we're starting to hear more about this possible relationship. One of them out of the University of Pittsburgh, they looked at individuals' genome sequence and then they followed the individuals for cognitive decline and different ADHD markers. Not necessarily that they had ADHD. And they did find some different associations. However, they concluded that it's not conclusive and they cautioned readers based on that research, not to overgeneralize the association, that more research is really needed. Another study out of Sweden, it was a larger scale study trying to look at a potential link between ADHD and dementia. And they took a different approach. They were looking across different generations and they looked at 2 million individuals. I can't imagine doing that volume of research between 1980 and 2001. And they did find that a small percentage of the individuals that they examined, I think it was like 3%, were diagnosed with ADHD. They looked at national registers and they pulled biological information on everyone's relatives. So they're just pulling together so much different information. And they looked at relationships between parents, grandparents, aunts, and uncles to see if those older generations develop dementia, and then if the generation had ADHD. So they kind of looked at it going backwards, and they did find that the parents of individuals with ADHD did have, I think it was a 30% increase incidence of having Alzheimer's disease or some type of dementia. Again, can they say that what came first? Is there some link between the genes? They're really not sure. Maybe they would theorize an undiscovered genetic variant that may contribute to both traits, or it's familial. So they said, well, is there some type of environmental risk factor that everyone was exposed to? And maybe in some of the individuals, it led to ADHD, and in others, it led to the different forms of dementia. Maybe something socioeconomically, looking at, like we've talked about, diet, exercise, different aspects, that lead to the different health conditions that lead to a relationship. Overall, most of the research at this time is saying that there, really isn't enough information to definitely say that there's an association, and more research is really needed to explore the underlying mechanisms of the associations that might be found in some of the research.